Hello, everyone. Welcome to our third literature update on COVID-19. Once again, I'm Aaron Richterman, the HIV Fellow at Brigham and Women's Hospital, and my co-presenter is Eric Meyerowitz, the HIV Fellow at Massachusetts General Hospital. We will be going through the published literature over about a 2-week period since our last update on April 8th, and our disclaimer is that these are our interpretations of these studies, and we encourage you to read the ones of interest in detail. Next slide, please. In total now, we have seen 6,277 COVID-19 related papers indexed to PubMed and 2,056 preprints posted to medRxiv or bioRxiv. And we'll be going through some of those that we found to be of the most critical importance in the last 2 weeks. Next slide, please. This is our agenda for today. We are going to spend some time going through quite a bit of new data around viral shedding and antibody dynamics before moving on to universal and random testing of certain populations, serosurveys, and an important modeling study in transmission dynamics. A great deal of pathologic studies are now becoming available, providing a growing insight into the pathogenesis of COVID-19, particularly with respect to extrapulmonary infection. We will spend a bit of time on updates in therapeutics, although unfortunately there continue to be few strong data available in this area. Next slide, please. Let's start with an update in viral shedding and antibody dynamics. Next slide, please. This was a very elegant study published in Nature on April 15th that confirms some features of viral shedding suggested by earlier studies we have referenced in prior talks. In this study, they looked at 414 throat swabs from 94 patients, collecting serial samples from symptom onset through up to 32 days later. None of these patients had severe disease on presentation, although 18 or 19 went on to develop it during their course. They found that viral loads were highest soon after symptom onset and gradually decreased towards the detection limit by around day 21. Although you can interestingly see at least one outlier that was negative after 3 weeks before having a positive test once again at day 28. These figures show comparisons by sex, age group, and disease severity, and they found no differences between the groups based on any of these characteristics. Next slide. In the same paper, they also evaluated 77 detailed transmission pairs, and based on the serial interval, i.e. the amount of time between the symptom onset in the transmitter and symptom onset in the transmittee, estimated that infectiousness started about 2.3 days prior to symptom onset and peaked at 0.7 days prior to symptom onset. They also found that the estimated proportion of pre-symptomatic transmission among this group was 44%, a figure largely in line with estimates from these two other important papers we have referenced previously in Emerging Infectious Diseases and Science. The authors point out, however, that the proportion of transmissions that are pre-symptomatic will vary greatly, depending on the aggressiveness of active case finding, with those places with high rates of active case identification and isolation likely to have a higher proportion of pre-symptomatic transmissions. Next slide. This is an important study to keep in mind as we are seeing more patients recover from prolonged critical illness. It was published in the American Journal of Respiratory and Critical Care Medicine on April 15th and looked at 16 consecutive critically ill patients at one center in China. They collected serial samples from the upper respiratory tract, throat and nasal swabs, and lower respiratory tract, sputum or endotracheal aspirates, daily for the first week of admission, and then every 2 to 3 days after the first week until they had 2 sequential negative results or the patient was discharged from the ICU. 15 of 16 had ARDS, 75% were on mechanical ventilation, and 25% received non-invasive positive pressure ventilation. ECMO was used in 31%. As of the time of publication, 9 patients were discharged from the ICU and all patients were still alive. During the ICU stay, nasal swabs were positive from 81%, throat swabs from 63%, and lower respiratory specimens were positive in all 100%. In the left figure, you can see that the viral load falls in the upper respiratory tract earlier than in the sputum, and 11 patients had viral shedding beyond 28 days in the lower respiratory tract. In the right figure, you can see that the lower respiratory tract specimens had lower cycle threshold values, implying a higher viral load when compared to nasal and throat swabs. All of this suggests that lower respiratory specimens may be preferable for SARS-CoV-2 PCR when there is a syndrome consistent with COVID-19 and a negative upper respiratory PCR. Next slide. This is a potentially very important preprint that was posted by a group from Yale earlier today on medRxiv. They collected 121 nasopharyngeal swabs and saliva samples from 44 COVID-19 inpatients, of whom 43% were critically ill and 23% required mechanical ventilation. As shown in the left figure, viral load was about 5 times higher in the saliva compared to the nasopharynx, and this remained true when examining only patient-matched pairs. They also identified SARS-CoV-2 from the saliva, but not the nasopharynx, in 8 matching pairs, while only detecting it in the nasopharynx, but not the saliva, in 3 matched samples. They also found that there was less temporal viral load variability in the saliva compared to the nasopharynx, as highlighted in the right two figures. They found a negative result later followed by a positive result in 5 instances with the NP swabs, but in no cases in longitudinal collections of saliva from 12 patients. Finally, they tested saliva against nasopharyngeal sampling among 98 asymptomatic healthcare workers at moderate to high risk of exposure. They detected SARS-CoV-2 in the saliva of 2 healthcare workers who were negative by NP swabs. Together, then, these preliminary data suggest that saliva may be more sensitive in both subclinical and early infection compared to nasopharyngeal swabs. The added benefit of saliva is that collection is less invasive and they can be reliably self-administered. Next slide. This is a study of 41 survivors after critical illness with COVID-19, published in CID on April 17th. They required 2 consecutive negative PCR tests separated by at least 1 day to be discharged. They found that the median duration of shedding was 31 days from illness onset, with the shortest duration of 18 days and the longest of 48 days. As you can see in this figure, there was no difference in length of viral shedding by age or sex. Next slide. And this phenomenon of prolonged viral shedding is not limited to severe disease, as illustrated by this study of 56 patients with mild to moderate COVID-19 published in CID on April 19th. They found that throat or nasopharyngeal PCR remained positive for a median of 24 days after symptom onset, with a 5% positivity rate at week 5. Of course, this does not imply that infectiousness lasts that long. Next slide. So we've gone through a number of papers about viral shedding today and during the last few presentations, and these are some of the key takeaway points of understanding that have come through. First, that nasopharyngeal viral load peaks around 1 day prior to symptom onset, correlating with the peak time of infectiousness. Second, that saliva may become an important sampling site for diagnosis. Third, SARS-CoV-2 is a descending infection, meaning that in later disease, viral loads are higher in the lower respiratory tract, especially in severe or critical illness. In mild cases, live virus has been isolated up to 8 days after symptom onset. Fifth, there can be prolonged shedding of viral RNA lasting many weeks. However, importantly, the correlation with infectiousness is unknown. Studies differ about whether severity of illness correlates with viral load. And finally, in some cases, viral RNA has also been identified in the stool, blood, conjunctiva, urine, CSF, and pleural fluid. Next slide. The last 2 weeks have seen a number of enlightening studies of universal or random testing and serosurveys. Next slide. This fascinating study was published in the New England Journal on April 14th and reviews the testing strategy in Iceland. First, where they used targeted testing from January 31st to March 31st, as depicted in the leftmost column, whereby they would test symptomatic persons from high-risk areas or those in contact with infected persons. Of over 9,000 tested, just over 1,000 were positive. The second testing strategy in the middle column was population screening through open invitation to the public from March 13th to April 1st, with the stipulation that participants had to be asymptomatic or have mild cold symptoms. In this phase, 87 of 10,797, or 0.8%, were positive. The third and final strategy on the right was directed invitation of a random sample from April 1st to 4th, with 2,283 participating out of 6,782 selected, and 0.6% of these positive for SARS-CoV-2. They used combined NP and oropharyngeal sampling, and everyone who tested positive was required to self-isolate until 10 days after a fever subsided if they had one, with close contacts required to self-quarantine for 2 weeks. Next slide. As you can see in the figure, sample collection for population screening began on March 13th, and the first positive test through population screening was March 15th. 1 day later, on March 16th, social distancing measures were put into place. The percentage of infected participants remained stable during the screening period, with the authors hypothesizing that the lack of increase was due to the containment efforts that began in mid-March. Among those testing positive, 93% were symptomatic in the targeted testing group and 57% in the population screening group, i.e., 43% of infections were asymptomatic or pre-symptomatic. Interestingly, 29% of those who tested negative in the population screening group reported symptoms. Next slide. This was a study published in the New England Journal on April 13th that followed up on the early report in AJOG that we referenced during our last presentation. After identifying 2 initially asymptomatic pregnant women who went on to develop symptoms, Columbia and New York City began universal screening of pregnant women presenting for labor with nasopharyngeal swabs. Between March 22nd and April 4th, they screened 215 pregnant women delivering infants. 4 had symptoms of COVID-19, and all 4 tested positive. 29, or 13.5%, were asymptomatic and positive for SARS-CoV-2. 3 of these, or 10%, developed fever prior to discharge, with the median length of stay of 2 days. 1 woman had a negative swab on admission, became symptomatic postpartum, and repeat testing 3 days later after the first swab was negative. Next slide, please. 2 important articles were published today in MMWR, confirming what many have feared about the vulnerability of the homeless and the system serving the homeless to this pandemic. In late March and early April, clusters of infections were identified from 5 homeless shelters in Boston, San Francisco, and Seattle. Universal screening of residents and staff was attempted at the shelters over a 1 to 2 week period, and overall 1,192 residents and 313 staff members were tested. You can see that in shelters reporting clusters here in red, there was a substantial amount of positive testing among residents, ranging from 17% in Seattle to 36% in Boston to 66% in San Francisco. Symptoms at the time of testing were not evaluated except for in Boston, which were reported in this preprint reference below. They found that symptoms were uncommon among the positive participants and similar in frequency to those with negative SARS-CoV-2. Next slide. In another universal screening story, this is a fascinating pilot study in Vaux, Italy, a town with a population of about 3,000, where the country's first death from COVID-19 occurred. After this death, researchers from the Imperial College in the UK, along with the University of Padua and the Red Cross, worked with local authorities who had quarantined the entire town and tested close to every person there. Next slide. The data from this experience was posted on medRxiv on April 18th. Just a couple days ago. In a manuscript, they describe how the municipality was locked down for 14 days after the person died from COVID-19, and how during this time the researchers collected information from the residents and did SARS-CoV-2 PCR testing at 2 different time points 12 days apart, with 85.9% participating in the first time point and 71.5% at the second time point. As shown on the figure in the way left, they found a prevalence of infection of 2.6% at the first time point and 1.2% at the second time point, with a quarter of those positive at the second time point representing new infections, as shown in the right bar in the figure in the middle. They did an extensive contact tracing analysis of the new infections identified at the second time point and found that the vast majority had contact with asymptomatically infected individuals either before the lockdown or from within their own household. 41% of those tested at the first time point were asymptomatic, and over half of the new cases identified at the second time point were asymptomatic. Interestingly, all asymptomatic but infected individuals identified at the first time point never developed symptoms in the interval between the first and second survey, with a high proportion becoming negative at the second time point. They found similar cycle threshold values from the PCR assay of asymptomatic and symptomatic individuals. All of this provides further evidence that asymptomatic infections likely play a key role in the ongoing transmission of SARS-CoV-2. 17% of the infected patients here required hospitalization. They estimated a serial interval of around 7 days prior to the lockdown and 10 days after the lockdown, with an effective reproductive number of 3 prior to the lockdown declining to 0.14 by the end of the lockdown, effectively ending the outbreak. Next slide, please. In Santa Clara, California, the first two cases of COVID-19 were identified January 31st and February 1st. Recall this MMWR down at the bottom right, discussed in our last presentation, where during an 11-day period in March, they found that 11% of influenza negative samples from people presenting to urgent care with respiratory illness tested positive for SARS-CoV-2, suggesting that this is one of the relative hotspots during the early American epidemic. Now, this preprint referenced below, which was posted April 17th, describes a seroprevalence evaluation in Santa Clara County done on April 3rd and 4th. This is the first large-scale community-based prevalence study with available data. At the time, Santa Clara County had over 1,000 confirmed cases of COVID-19. The authors recruited participants with advertisements on Facebook targeted to be representative by zip code and sociodemographic characteristics. Participants who clicked on the link filled out a REDCap survey and were directed to a drive-through test site that performed a premier biotech lateral flow immunoassay for IgM and IgG. A combination of the authors and the manufacturer's validation suggested a sensitivity around 80% and a specificity of 99.5%, although with large bounds in those figures. The study included the 3,330 individuals who registered for the study, came to the study site, and were able to have the samples collected. The crude prevalence of positive IgM or IgG was 1.5%. To estimate population prevalence, they weighted the raw frequencies by zip code, sex, race, ethnicity, and by several other scenarios of assumptions about the test characteristics of the assay. But unfortunately, there appears to have been some errors in the calculations, and in combination with the caveats surrounding volunteer bias, i.e., that those who volunteer for the test may be systematically more or less likely to be positive relative to the general population, as well as the fact that their estimates were highly sensitive to the test characteristics, in particular the specificity. All that can be concluded here is that the overall prevalence, while substantially higher than the number of identified cases, remains quite low. Next slide. Now, to dig in a little bit more about the variability between different antibody assays, in this preprint posted on April 20th, Adams and co-authors used laboratory-based ELISA assays as well as 9 different point-of-care lateral flow immunoassays targeting IgM and IgG to the spike protein of SARS-CoV-2 and compared their performance on a panel of 40 samples designated SARS-CoV-2 positive and 142 samples designated negative. While maintaining thresholds for 100% specificity, the ELISA test had 85% sensitivity versus RT-PCR, with all false negatives from samples taken within 9 days of symptom onset. This is illustrated in the top panel of figures, where the left panels are the pre-pandemic controls, with blue being negative ELISA results, and the middle panel being those from the acute phase, and the one on the right being from the convalescent phase, or greater than 28 days after onset, with the orange being positive readings and blue being negative. Sensitivity of antibody detection by lateral flow immunoassay relative to ELISA ranged from 65 to 85%, with specificity ranging from 93 to 100%. This is illustrated by the figure on the bottom, where each row represents a different assay, and again, the left panel is pre-pandemic controls, middle is the acute phase, and right are convalescent cases. On the left, orange areas represent false positives, and 9 of 50 samples tested on both ELISA and all the LFIA devices generated at least one false positive on 7 different LFIA devices. 4 samples generated false positives on more than one device, potentially suggesting something cross-reacting to, for example, the other endemic betacoronaviruses or some other antigen on some of the LFIA platforms. In the middle and the right, you can see that the false negatives are here in blue. The authors illustrate the consequences of even a small deficit of specificity in the figure on the left, where in a situation of 5% population prevalence, as seen in the leftmost panel, and 95% specificity, as shown in the blue line, upwards of 50% of positive tests will be false positives. This study provides an important word of caution when interpreting serology, particularly results from lateral flow immunoassays, which the authors suggest are currently inadequate for most individual patient applications. Next slide, please. In summary, then, with studies of near universal screening of various populations becoming more available, we are finding varying rates of PCR positivity, with greater than 40% of identified infections in asymptomatic individuals, with variation probably driven by the local stage of the epidemic, the population and sampling method, and mitigation strategies in place at the time of the study. At least some of the asymptomatic infections identified are actually probably pre-symptomatic, given the variable and sometimes lengthy incubation period. And the first large serosurvey with available data suggests a low prevalence of infection to date, albeit much higher than the number of known cases. Next slide. This is an important modeling study that was published by Kistler and co-authors last week on April 14th in Science that has some important implications for population level control of SARS-CoV-2. And so we're going to spend a little bit of time going through the details. Next slide. To start, they looked at the two endemic beta coronaviruses, OC43 and HKU1, which typically cause asymptomatic or mild upper respiratory infection and are one of the most common causes of the common cold. They cause annual outbreaks in winter, which suggests that wintertime climate and human behaviors during the wintertime facilitate transmission of these viruses, just as they do for influenza. Immunity to these beta coronaviruses wanes typically within about a year. They used a weekly percentage of positive lab tests for OC43 and HKU1 and multiplied them by the population weighted proportion of physician visits due to influenza-like infections each week to approximate historical incidence. They estimated the weekly effective reproductive number and found a seasonal pattern, with annual peaks in the winter and effective reproductive number of 1.85 for HKU1 and 1.56 for OC43. As shown here, they then quantified the relative contribution of immunity versus seasonality on the transmission dynamics of these endemic beta coronaviruses. In the figure, the top row is for HKU1 and the bottom for OC43, with the y-axis being the multiplicative effects on the effective reproductive number of HKU1 incidence in red, OC43 incidence in blue, and seasonal forcing in gold, with the black dot at the start of each season being the estimated coefficient for the strain and season compared to the 2014 season, which is the first one listed here. And so you can see while the depletion of susceptibles for each strain was negatively correlated with transmissibility of that strain, as shown, for example, by the decline in blue in the bottom left panel, it was also negatively correlated with the reproductive number of the other beta coronavirus, as shown by the decline in red in the second panel in the bottom row. This suggests some element of cross-immunity, although the effect of the opposite strain was always less than that of the strain itself. Seasonal effects were suggested to play a larger role earlier in the season, as you can see in each panel, while depletion of susceptibles played a larger role toward the end of the season. The coefficients relative to 2014 were consistent across season and lacked correlation with incidence in prior seasons, consistent with immunity waning within a year. Next slide. Now they've added a third coronavirus, SARS-CoV-2, to the model. In this figure, black represents SARS-CoV-2 and red and blue are the other endemic beta coronaviruses. In this figure, they evaluate the impact of varying durations of immunity to SARS-CoV-2 and find that a duration of 40 weeks, as shown on the left, predicts annual outbreaks, while a slightly longer immunity of 104 weeks predicts outbreaks every other year, with smaller outbreaks in intervening years. Next slide. Here they assume long-term immunity and find that it consistently predicts effective elimination in their models, including the elimination of the other beta coronaviruses if there is at least 70% cross-immunity, which is the same level that OC43 induces against HKU1. Next slide. In this scenario, they assume that SARS-CoV-2 immunity lasts for 2 years and that there is mild 30% cross-immunity from the other coronaviruses. This would lead to effective elimination for up to 3 years before a resurgence in 2024. Next slide. If there is high seasonal variation, i.e. a large summertime decrease in the effective reproductive number, there will be low transmission as we head into the summer, leading to recurrent outbreaks with higher peaks in the post-pandemic periods in the wintertime. Next slide. They then went on to assess social mitigation strategies. To do this, they made several important assumptions to keep in mind. First, based on work from the Imperial College in the UK, they assumed that 95.6% of cases would be moderate, mild, or asymptomatic, 3.08% would require hospitalization but not critical care, and 1.32% would require critical care. Second, they assumed a worst-case scenario of no cross-immunity from the other beta coronaviruses. Third, they assumed a latent period of 4.6 days and an infectious period of 5 days, based on literature we have previously outlined. Fourth, they assume a mean duration for non-critical hospitalization of 8 days and an additional 10 days for hospitalization requiring critical care. Fifth, they varied the reproductive number between 2.2 to 2.6 in wintertime and allowed the reproductive number to vary between 60% to 100% of that value in the summertime. Finally, they assumed 0.89 free beds per 10,000 adults as the benchmark for critical care demand. The intervention they were interested in evaluating was an on-off threshold for social distancing, with the on threshold chosen somewhat arbitrarily to be 35 cases per 10,000 people, and the off threshold being 5 cases per 10,000. Okay, so that being said, let me orient you to the figure you'll be looking at. On the left is prevalence over time, with different lines representing varying levels of reduction of the reproductive number during the blue box period of social distancing, with the reductions indicated below by a different color. The solid lines represent cases, corresponding to the left y-axis, and the dashed lines represent critical cases, corresponding to the y-axis on the right. On the right is cumulative incidence, with the colors corresponding to those in the left figure, and the gray line representing an approximation of herd immunity at 50%. In this first scenario, they found that one-time social distancing efforts, here in dark blue, of varying effectiveness and duration, substantially reduced the initial epidemic period, and that under all scenarios, there will be a resurgence of infection when social distancing is lifted. In some scenarios, as illustrated in the case of a 20-week social distancing period with 60% reduction in the reproductive number, in green, the resurgence peak was nearly the same as the initial peak without social distancing. Social distancing in this case was too effective to lead to any important increase in population immunity. Next slide. With the addition of seasonal variation, the post-intervention resurgent peak could have a higher peak prevalence and total number infected compared to the initial epidemic without intervention. If there is seasonal variation, none of these one-time interventions maintain the prevalence of critical cases below capacity. Next slide. In the next two figures, you'll see that the timeline has been stretched out, and now the black line is cases corresponding to the left y-axis, and the red line is critical care cases corresponding to the right y-axis. The blue shaded areas are periods of social distancing, and the dashed gray lines are the on and off levers for social distancing. The solid gray line is the critical care capacity here in the left figure, which in this scenario you are looking at is assumed to be double what we have currently. With these on and off levers, intermittent social distancing could prevent us from reaching this critical care threshold that is twice our current capacity, although with relatively frequent implementation through 2022. This doubled capacity also allows population immunity to be accumulated more rapidly, reducing the overall duration of the epidemic and the total length of social distancing measures. Next slide. Finally, if there is seasonal variation in transmission, which, to be fair, we have no current reason to suspect, the amount of time required to have social distancing over the next 2 years would be less. Next slide.
Okay, we're gonna shift gears here and talk about a couple other topics. So the last 2 weeks, there have been several remarkable series published with pathology that correlates to some of the pulmonary and extrapulmonary manifestations of COVID-19 that we're seeing in the hospital every day. Surely there will be much more to come about this topic, but with these initial studies, we can start to think more about the pathophysiology of some of the clinical syndromes that we're seeing. So one of the clinical syndromes that is rare but well described in COVID is myocarditis, and this can sometimes present fulminantly. On April 8th, the European Heart Journal reported the first case of COVID-related myocarditis with endomyocardial pathology. They described the case of a 43-year-old woman without significant past medical history who presented to the ED with 3 days of chest pain and shortness of breath. She was RT-PCR positive for SARS-CoV-2 from nasopharyngeal swabs. She had ECG changes along with elevated troponin and BNP. Her echocardiogram showed left ventricular systolic dysfunction with an ejection fraction of 43% and inferolateral wall hypokinesis. Additional advanced imaging studies including CTA and MR showed hypokinesis of the left ventricle at the mid and basal segments with normal apical contraction suggestive of a reverse Takotsubo pattern. She was treated with lopinavir, ritonavir, and hydroxychloroquine, and she fortunately had significant systolic recovery by hospital day 7. The imaging study she had confirmed diffuse myocardial edema at involved sites, and on MR she had late gadolinium enhancement without scar or necrotic foci. She underwent endomyocardial biopsy on day 7 of her right ventricle, and this showed diffuse T lymphocytic inflammatory infiltrates with interstitial edema. There was no fibrosis, and again, it was all suggestive of an acute inflammatory process. No SARS-CoV-2 genome was found within the myocardium, and no microvascular abnormalities were noted. They also did molecular assays for a number of other viruses, including all the usual viruses that are associated with myocarditis, and all of those were negative. So overall, the diagnosis was acute virus-negative lymphocytic myocarditis associated with COVID-19. On April 9th, the first report of kidney pathology in patients with SARS-CoV-2 was published, and that's seen here. So this series described the autopsies of 26 patients with COVID-19 from a hospital in Wuhan, and that included 19 males and 7 females. And again, this is the first pathologic evidence that we were aware of systemic involvement of SARS-CoV-2 viral infection. So the first confirmation on pathology of SARS-CoV-2 outside of the respiratory tract. Many patients in this series had extensive acute proximal tubule injury. So on the left here, you can see virus particles in the cytoplasm of proximal tubular epithelial cells within the kidney. They note the diameter of the particles was between 65 nanometers and 136 nanometers, with the distinctive corona spikes that are from the S protein, and these were 20 to 25 nanometers. The red arrow points to the virions, and the green arrow highlights the characteristic spikes. On the right here, you can see the indirect immunofluorescence staining with anti-SARS-CoV-2 nucleoprotein antibody within kidney tissue. They noted an expected mix of T and B cells and scattered macrophages. They also noted strong ACE2 expression in the proximal tubules, particularly in the areas with significant injury. They found abundant erythrocytes and obstructive peritubular capillary lumens with activated endothelium, though they did not find evidence of virus within the endothelium, at least in this series. In 3 cases, they found pigmented casts and associated high levels of creatine phosphokinase consistent with rhabdomyolysis. Interestingly, the authors noted that CD147, which again has been proposed to be another possible entry protein for the virus, is highly expressed on the surface of proximal tubule epithelial cells as well as the infiltrating inflammatory cells. Next, on April 10th, the European Journal of Heart Failure published a very interesting report in which they confirmed the first localization of SARS-CoV-2 within the heart. So this was the case of a 69-year-old man from the Lombardy region of northern Italy. He had cough, weakness, and progressive shortness of breath over 4 days. He was admitted to the hospital and found to have COVID-19 with bilateral pulmonary infiltrates. His labs were notable for a marked leukocytosis to greater than 23,000 with 91.4% neutrophils, along with markedly elevated troponin. His first echocardiogram showed a dilated left ventricle with severe and diffuse hypokinesis, and his ejection fraction fell markedly actually over hours after he was admitted to around 25% with an estimated cardiac index of 1.4. He was intubated and then subsequently placed on ECMO. He had recovery of his cardiac function over about 5 days and was eventually decannulated from ECMO. But unfortunately, he died 12 days after coming off of ECMO from gram-negative rod sepsis. He underwent an endomyocardial biopsy while he was on ECMO, which showed some low-grade inflammation with prominent vacuolated macrophages that were CD68 positive. And they also found viral particles between 70 and 120 nanometers with characteristic corona spikes seen. They didn't perform molecular analysis on these particles, but they compared the particles to Viro E6 cells that they had inoculated with SARS-CoV-2 and found the particles to be the same. These particles were found in the interstitial cells near myocytes, but it's important to note no viral particles were found within the cardiac myocytes in this case. These authors suggested that these findings are not consistent with true fulminant viral myocarditis, but might be consistent with tissue damage from the sort of cytokine storm that has been hypothesized to drive some of the clinical findings seen with COVID-19. I know we and many others have been seeing a lot of evidence of hypercoagulability, particularly in our critically ill patients with COVID, including with venous and arterial clots. There were 2 papers released on April 9th and 10th, which showed very high rates of PEs and VTE for patients with COVID who were in the ICU. And we'll discuss one here. The reference for the second one is at the bottom of this slide. So this figure comes from a Dutch study that included 184 ICU patients. All patients had COVID-19, and at the time of writing, 13% had died, 12% had been discharged alive, and 76% were still in the ICU. All of these patients received at least standard doses of prophylactic anticoagulation, and they had a composite endpoint of symptomatic acute pulmonary embolism, deep vein thrombosis, ischemic stroke, myocardial infarction, or systemic arterial embolism. They show the cumulative incidence of that composite endpoint here, and it was 31% in this series, and you can see that demonstrated here. VTE was confirmed in 27%, with PE being the most frequent complication. Increasing aged, a greater than 3-second prolongation of PT or a greater than 5-second prolongation in APTT were all independent risk factors for thrombosis. And they also found arterial thrombotic events in 3.7% of cases. One of the most important questions that clinicians and researchers have been asking is what is behind the pathophysiology of all of this clotting that we're seeing. So on April 17th, The Lancet published the first definitive evidence of SARS-CoV-2 endothelial infection in a series that included sections from 3 patients. The first patient was a male with a history of a kidney transplant, coronary artery disease, and hypertension. He died of multisystem organ failure, and his autopsy revealed viral inclusions in endothelial cells of the transplanted kidney. The second patient was a 58-year-old woman with diabetes, hypertension, and obesity, and she actually developed mesenteric ischemia from infarcted small bowel and subsequently died. On autopsy, they found lymphocytic endotheliitis in the lung, heart, kidney, and liver with associated liver cell necrosis. They found histologic evidence of myocardial infarction, but no signs of lymphocytic myocarditis. Histology of the infarcted small intestine showed endotheliitis of the submucosal vessels. The third patient was a 69-year-old man with hypertension who developed mesenteric ischemia and survived after a bowel resection. Histology on the resected small intestine revealed prominent endotheliitis of the submucosal vessels and apoptotic bodies. The authors note that they found evidence of direct viral infection of the endothelial cell and diffuse endothelial inflammation. And you can see the viral particles within the endothelium, as well as the diffuse and endothelial inflammation seen in the slides. They note the critical importance of this finding, specifically that endothelial dysfunction leads to microvascular dysfunction, which can lead to organ ischemia, as was seen in all of these cases. So next, we want to walk through a very interesting series of 5 cases that was published in Translational Research on April 18th. They suggest that in some patients, there may be a virally induced complement-mediated microvascular injury with associated thrombosis. So this slide is from lung autopsy images from the first case in their series. So this was a 62-year-old man with a history of multiple comorbidities. He presented to the ED in extremis with severe hypoxemia and bilateral infiltrates and died a few hours later. These images show destructive vascular injury. So this is from his lung, including with fibrin deposition and hemorrhage, as you can see throughout here. And there's fibrinoid necrosis of his septal capillaries as well. And so, again, significant septal capillary image here. On the right, this is immunohistochemical staining of various complement products, so including C4D, C5b9, and C3D. And what they found was, again, complement deposition within the septal capillaries. This was the second case in the series, which these are sections from the lung and showed very similar findings to the first case. The third case was a 32-year-old with obesity who presented with a week of fever and cough. He eventually required intubation. and had an elevated D-dimer, which peaked over 2,000 nanograms per milliliter. He was intubated for over 3 weeks and received hydroxychloroquine, azithromycin, and remdesivir. Early on, he developed this purpuric rash on his buttocks, and skin biopsies showed thrombogenic vasculopathy with extensive necrosis of the epidermis and adnexal structures. And he had significant neutrophilic interstitial and perivascular inflammation. And here again, you can see immunohistochemical stainings that shows extensive deposition of C5b9 in a similar distribution. The next was another case of 66-year-old woman without significant medical history. She had 9 days of symptoms, was hypoxemic, required intubation and renal replacement. She was on hydroxychloroquine and prophylactic enoxaparin. And on hospital day 10, she developed mild thrombocytopenia with marked elevation of her D-dimer to greater than 7,000 nanograms per milliliter. And then she developed these purpuric lesions on their palms and soles. The skin biopsy showed vascular ectasia and occlusive thrombus within the arteries of the deep dermis without associated inflammation, but also with extensive vascular deposits of C5b9, C3d, and C4d. Unfortunately, she also developed multifocal supra and infratentorial cerebral infarctions. This is the 5th case from the series, and this was a 40-year-old woman without significant medical history. She presented with 2 weeks of symptoms. She had significantly reduced left ventricular ejection fraction, and was intubated for respiratory failure and shock. Her D-dimer was elevated to greater than 1,100 nanograms per milliliter, and she developed this kind of lividoid reticulated rash on her chest, arms, and legs. The skin biopsy showed perivascular lymphocytic infiltrates with deeper-seated small thrombi within the venules of the deep dermis. She also had perivascular deposits of C5b9 and C4b. This figure shows the co-localization of SARS-CoV-2 envelope proteins with complement components. So here, these are lungs sections from the first case, and you can see the coronavirus proteins are stained in red, and they've tagged the complement components in green. So up here, these components are C4d, and you can see that they overlay quite well. So again, suggesting co-localization of these. And down here, you can see strong co-localization of C5b9 with the SARS-CoV-2 envelope proteins. This is similar findings from the skin of one of the other patients. And so these authors, when they put together this interesting pathology from these 5 cases, and really they suggest that the findings are consistent with the generalized complement activation and associated thrombotic microvascular injury. They report it's quite rare to have this extensive deposition of terminal complement complex C5b9 and C4d. They also note that the findings in the lungs, importantly, are very different from the typical diffuse alveolar damage that's seen in the usual form of ARDS. And they propose a possible mechanism for generalized complement activation in the setting of COVID. They postulated that extensive complement activation with associated membrane attacks complex mediated microvascular injury and subsequent activation of the clotting pathway might be the result of all of this. In some areas where they saw neutrophils in tissues, they note that this might be because of the chemoattractant properties of complement for neutrophils. They note that the mechanism of complement activation is not clear and does need to be worked out, but they do note that mannan-binding lectin was found to bind to the spike protein of SARS-CoV, and that this could be the first step in activation of the lectin pathway, leading to a cascade of further complement activation. So again, it's not clear that mannan-binding lectin binds to the spike protein of SARS-CoV-2, but that's something else that needs to be studied further. This is a summary slide going through all of the references that we just discussed and some of the proposed pathologic correlates of various clinical presentations. So clearly much more is needed in this area and needs to be worked out, but we have certainly learned a lot over the last several weeks. From this accumulating data, there is evidence of at least 3 different mechanisms of cardiac injury. The first is lymphocytic myocarditis. The second is associated with virus and macrophage infiltration of the heart, which perhaps may be related to an overall cytokine storm. And the third is myocardial infarctions from virally driven lymphocytic endotheliitis and associated clotting. There may be some other mechanisms of cardiac injury too, and now we can start to think perhaps about what specific treatments might be deployed depending on the context and on the specific pathology for particular cases. The lymphocytic endotheliitis and complement deposition pathways that have been proposed also need to be explored further. Are these processes related? Does viral endotheliitis lead to complement and endothelial activation and damage, or are these 2 distinct processes that happen differently? Again, as we see much more pathology studies over the next weeks, I suspect we'll learn much more about these topics. So this was a very interesting and important study that was published in Cellular and Molecular Immunology in the last 2 weeks, and it shows that SARS-CoV-2 directly infects lymphocytes. So if we start on the right side of the screen, what they did was they inoculated various cell lines with SARS coronavirus and SARS-CoV-2, and so the lines that they inoculated, there were 2 T lymphocyte lines. One was MT2 and the other was A3.01. Both of those are T lymphocyte lines, which had extremely essentially negligible expression of ACE2. The third line was a 293T ACE2 line, and this has significant ACE2 expression. And again, here you can see the relative ACE2 expression of the lines. Note the difference in the y-axis, the cutoff here. And essentially there's negligible ACE2 expression in these lines. So going back to the left side of this slide, what you can see is the infection ability of each of these viruses. First, for this ACE2 expressing line, they both are able to gain viral entry and infect the cells. As we move on to these 2 lymphocyte lines, the MT2 cell line and then the A3.01 cell line, you can see that SARS-CoV-2 is able to gain entry here where SARS-CoV is not. And so they further in the paper show that this is through a spike protein non-ACE2 receptor bound mechanism, and they postulate that it could be perhaps related to the CD147 protein that's been discussed in the past, or perhaps there's even more to this viral entry story. So we've heard a lot about IL-6 over the last few months, particularly as it relates to COVID, and this was a particularly interesting study that was published in CID recently, and it's a cohort of 48 patients from a hospital in Wuhan. This cohort included 21 patients with moderate disease, 10 with severe disease, and 17 with critical disease. Critically ill patients had to meet either any of the following criteria. So they needed respiratory failure requiring mechanical ventilation, shock or multi-system organ failure requiring ICU level care. All of the patients in the cohort had serum viral load testing, and only 5 had positive serum viral loads. They all were critically ill patients. So these critically ill patients had many of the usual markers that have previously been reported to be associated with severe COVID, including higher neutrophil counts, lower absolute lymphocyte counts, and higher procalcitonin levels. But the authors noted a sharp increase in IL-6 levels among the critically ill patients, of nearly 10 times that of severe patients. So the table here shows that there was a high correlation of having an IL-6 level greater than 100 picograms per milliliter with having viremia. So all 5 of the patients who had viremia had an IL-6 level greater than 100, and only 1 other patient in this cohort had an IL-6 level that high. On the right here, you can see the difference in the IL-6 levels for those with and without viremia. So again, here in red, you can see the levels for the viremic patients, and here are the levels for the non-viremic patients. The authors here postulate that IL-6 may be an important biomarker of prognosis. We know that from previous studies. Or it's possible that it's a direct driving force for progressive disease that we're seeing in some severely ill patients. So we also wanted to highlight this other reference, this Science article that was published in the last week. And these articles review the IL-6 pathway and compare what's happening in COVID to what happens in the cytokine release syndrome that can be seen after CAR T cell therapy. So these authors note that with high circulating IL-6 levels, IL-6 can bind to a soluble form of the IL-6 receptor. This can then complex with a ubiquitously found membrane-bound protein called GP130. And this can set off an IL-6 induced JAK-STAT3 signaling pathway and lead to a cytokine storm. So a cytokine storm is essentially a pro-inflammatory cascade with many cytokines released. And one of the things that is prominent is reduced E-cadherin expression on endothelial cells. So E-cadherin helps the cells stay kind of close together and decreases permeability. When E-cadherin expression goes down, you get increased vascular leakage and permeability. So because of this, COVID, it's possible that viremia is independent and that there is really a sort of an uncontrolled viral process, or it's possible that this IL-6 induced cytokine storm and associated vascular leakage is actually leading to this finding of viremia in these patients. Furthermore, the authors of this Science article note that IL-6 receptor blockade has not been associated with worsening viral infections in other settings. They are thinking about that because of the concerns about using this in the setting of an acute SARS-CoV-2 infection. They do, but clearly this needs to be studied. Again, the implications are very different. If cytokine storm is the major cause of morbidity, we need to address that directly with IL-6 blockade. If all of this is due to uncontrolled viral infection, then we clearly need safe, effective antivirals for progressive disease. And it's possible that we need both of these things at the same time. We wanted to say a brief word about this study. This was a study of cytokine profiling. So they included 344 severe and critically ill patients from 8 intensive care wards in China. And they confirmed a lot of the same risk factors for severe disease that we know from other studies. But they did perhaps the first really detailed cytokine profiling and found a number of differences in cytokines for survivors compared to non-survivors. And that includes higher levels not just of IL-6, but of IL-2 receptor, IL-8, IL-10, and TNF-alpha. And so we do think we'll be hearing a lot more about this again in the time ahead. Now we're going to do some updates on therapeutics. So we wanted to highlight this study that was published in Science, which showed the structure of the SARS-CoV-2 RNA-dependent RNA polymerase, or RDRP. This is also called the non-structural protein 12, or NSP12. This is a centrally important enzyme in viral replication. And the authors express the enzyme with its cofactors. They note that it's conformationally very similar to the RDRP from SARS-CoV. And they suggest potential binding sites and binding mechanisms and inhibition mechanisms for remdesivir, based on these structural findings. Up until the last 2 weeks, there was no in vivo data for remdesivir. And so we want to just go through a couple studies quickly here. So this is the study that looked at remdesivir in rhesus macaques. So 2 groups of 6 monkeys were inoculated with SARS-CoV-2. And starting 12 hours after inoculation, some of the monkeys received remdesivir and others received a control treatment. The scientists found the remdesivir group had less radiographic infiltrates, less tachypnea, less dyspnea compared to the control group. And they found that infectious virus titers from BAL samples were 100-fold lower than remdesivir on day 1 and couldn't be detected by day 3 in this group, which was different than the control group. On these charts, you can see the differences in the lung for the remdesivir group compared to the control group. So there was much less area of the lung that was affected with gross lesions. There was a lower lung weight to body ratio in the remdesivir group compared to the control group. And there were fewer histologic changes in the remdesivir group compared to the control group. So this here shows that that remdesivir didn't affect. There was no difference in the viral load between the remdesivir and the control groups. However, there was a significant difference in the infectious virus titer between the remdesivir and the control group. And this was even true very early on. So even within the first day after treatment, there was a significant difference in the infectious virus titer between these two groups. And you couldn't detect any infectious virus in the remdesivir group after 3 days. On the other hand, they could isolate infectious virus from the control group in 5 out of 6 members on day 7 after all of the animals had been euthanized. And just one more word on this. So the fact that the viral loads weren't different between the two groups may suggest that this is not a good endpoint for other therapeutic trials, and perhaps not even for return to work or for clearance of infection control flags at hospitals and care facilities, given the differences that are being described here in terms of just viral load versus infectious virus titer. This was, so the first human data for remdesivir was published in the New England Journal on April 10th, and this was a non-randomized series of 61 patients who received remdesivir as compassionate use. And the authors analyzed data for 56 patients, and they presented it nicely here in this figure. It was a sick group, nearly 70% with comorbidities and 64% on invasive ventilation. They had a median of 18 days of follow-up, and 68% had some improvement in oxygen support. 13% had died. The patients received the remdesivir a median of 12 days after symptom onset. But it's important, obviously, to note there was no comparison group in this study, so it's not possible to infer anything about the efficacy of the drug from these data alone. We did want to mention this exciting new orally bioavailable drug, which is going to be under study, for this disease. So this drug is called beta-D-N4 hydroxycytidine, or NHC, and it is a ribonucleoside analog, and it's available in a highly bioavailable form, and it has broad spectrum antiviral activity. It's thought to incorporate into viral genomes and result in inactivating mutations. So the figure on the left here shows that NHC has a inhibitory effect on SARS-CoV-2 in human airway epithelial cells that's dose dependent. So starting on the right here, DMSO is the control. You are able to get high levels of virus production within these cells, and as you increase the concentration of NHC, the level of virus production goes down. They also did not observe cytotoxicity with this agent. They also found that it had potent antiviral activity against remdesivir-resistant virus as well as against zoonotic bat coronaviruses. So then they tested an orally bioavailable prodrug of NHC called EIDD2801 in a mouse model of SARS coronavirus. So they gave the drug to the mice at various time points after infection with SARS coronavirus, and they found that the treated mice had less weight loss, less lung hemorrhage, lower viral titers in the lungs, and reduced acute lung injury and diffuse alveolar damage on pathology. So again, this is a promising agent, and clinical studies are being planned for the near future, so it's something to watch out for. We wanted to end with a few updates on hydroxychloroquine and chloroquine. So over the past 2 weeks, 3 large data sets of hydroxychloroquine for the use of COVID have been reported. The first was this retrospective series, which was an analysis from 4 French hospitals that included 181 patients. They included 84 who were on hydroxychloroquine within 48 hours of admission, and 97 who were not. All of the patients in the study were on at least 2 liters of supplemental oxygen, and the primary endpoints were transfer to ICU or death from any cause within 7 days. And they found no benefit to hydroxychloroquine. And they also noted that 10% of patients who received hydroxychloroquine needed it discontinued because of QTc prolonging issues. The second study was reported on medRxiv on April 14th, and it's this multi-center randomized controlled trial of 150 hospitalized patients with COVID. 75 were assigned to the hydroxychloroquine plus standard of care arm, which is shown in blue, and 75 were assigned to the standard of care arm, which was the control group. They used quite high doses of hydroxychloroquine here, so a loading dose of 1,200 milligrams daily for 3 days, followed by a maintenance dose of 800 milligrams daily for the remaining days, and they gave 2 to 3 weeks of the drug, depending on how severe the case was. The primary outcome that they selected was seroconversion, was conversion to negative RT-PCR from an upper respiratory tract specimen by day 28. And as you can see here, they found no difference between the hydroxychloroquine or no hydroxychloroquine treated groups. They also didn't find a difference in improvement of symptoms, although when they did a post hoc analysis controlling for use of other antivirals, they did report faster symptom improvement in the hydroxychloroquine group. They also showed faster improvement in CRP in the hydroxychloroquine group. It is important to note this study, randomization occurred quite late in disease, so the mean day of randomization was 16.6 days after onset of symptoms. On April 21st, this study was reported as a preprint on medRxiv from the Veterans Affairs, from some Veterans Affairs researchers in the US. This group performed a retrospective analysis on data of hospitalized patients with COVID at VA facilities in the US from March 9th to April 11th. They compared standard of care to hydroxychloroquine exposure with or without azithromycin, and the 2 primary outcomes were death and the need for mechanical ventilation. So they identified 385 patients, but they analyzed 368 male patients. There were only 17 female patients, and so they excluded these because they felt they couldn't analyze that small subset robustly with such a small size. So they included 158 who had no hydroxychloroquine exposure, 113 who were given both hydroxychloroquine and azithromycin, and 97 who were treated with hydroxychloroquine alone. To account for the non-randomized assignment of the treatment groups, and since hydroxychloroquine tended to be prescribed for patients with more severe disease, they did use propensity score adjustment for multiple variables. Their major finding was that compared to those who did not receive hydroxychloroquine, the risk of death from any cause was higher in the hydroxychloroquine group, but not in the hydroxychloroquine plus azithromycin group when compared, again, to the no hydroxychloroquine group. And you can see that in the table here, including the percentages of death in each group. In their adjusted hazard ratio model, they found the risk of death in the hydroxychloroquine group was higher with an adjusted hazard ratio of 2.61. They did not find statistically significant changes in the need for ventilation between the groups, and no differences between, again, the group that was treated with the combination of azithromycin and hydroxychloroquine. A study from Brazil was stopped early because of safety concerns. So this study, they used high-dose chloroquine at 600 milligrams BID for 10 days, compared to lower-dose chloroquine of 450 milligrams BID for 1 day, and then daily, 450 milligrams daily for 4 more days. All of these patients also received ceftriaxone and azithromycin. They enrolled 81 patients out of a pre-specified 440 sample size. In the high-dose chloroquine arm, 25% developed a QTc greater than 500 milliseconds, and there was a trend towards higher mortality. So in that group, 17% versus 13.5% in the lower group. They also did not find any evidence of rapid clearance of virus from samples, And so they concluded that the high dose chloroquine was not sufficiently safe to warrant continuation of the study at that dose. So here we've compiled a reference slide with most of the currently available data for chloroquine and hydroxychloroquine, again, with references on here. Our takeaway is that there is accumulating data with some better quality studies published more recently, and yet there's no clear signal of benefit, and there is certainly some evidence of harm, particularly with higher doses of these agents. For this reason, many institutions are moving towards only using these agents within the context of carefully controlled clinical trials. So to summarize, we covered a lot of material here, but just to summarize a few key points. Peak infectiousness is likely about 1 day prior to symptom onset. Viral shedding can be prolonged, but correlation with infectiousness is unknown at this point. Universal screening of high-risk populations is an important tool that we expect to see more of. In the absence of effective therapies or vaccines, intermittent social distancing is likely to be needed for years in order to avoid overwhelming critical care capacity. We also discussed some of the emerging pathologic correlates of clinical presentations, including multiple mechanisms of cardiac injury, some evidence of viral infection systemically, and some possible explanations for some of the micro and macro thrombotic events that we're seeing, including viral endotheliitis and possible generalized complement activation. We talked about some of the first remdesivir in vivo data, and that showed clinical benefit in animal models, with the caveat that it was given quite early in the disease course to those animals. And we discussed that the accumulating hydroxychloroquine and chloroquine data doesn't show a clear benefit, at least at this point. So we want to thank you again, and thanks.
All right. I'm going to end this, but we'll be in touch.
Great.